Okay? Well, if you come across any questions later on, I'll, just email me or come and see me. I'll try and remove any confusion if there is. Now we're just going to be spend the rest of the time talking about autoimmunity. Autoimmunity is just quite the reverse of tolerance, okay? As I told you again and again, we're normally tolerant, do not react immunologically to our own tissues and cells, but there are some unfortunate individuals. They are somewhat genetically predisposed to such that they start reacting against their own antigens. And autoimmunity can be defined as a breakdown of mechanisms responsible for tolerance. The autoreactivity may result in disease. Autoreactivity does not always result in disease. As a matter of fact, it's a part of normal physiology. Dr. Mayer told you about. We all produce anti-idiotypic antibodies. That's against self. Okay? Those are regulatory antibodies. If I were to test all of you in this room and test your serum and test it for anti-nuclear antibodies, I'll find a good number of you have got anti-nuclear antibodies. They're in low titer, they're not harmful. As a matter of fact, they are sometimes postulated as they remove the nucleic acid very quickly from the circulation, okay, and do not perpetuate induction of anti-nuclear antibodies that are harmful. Okay? So some of them are, those autoantibodies can be good and part of normal physiology. Autoimmunity is classified as our autoimmune disease only when those autoreactive antibodies or T cells start causing harm to self. What are the immune components involved in autoimmune diseases? Just like any other immune reactivity. Antibodies, T cells, the cytokines produced by those T cells, the non-specific components that are recruited as a result of those cytokines or antibodies. Complement is involved, of course. When there's antibody reacting with the tissue, complement gets activated, and there's complement-mediated lysis, phagocytes, red cells in hemolytic anemias, autoimmune hemolytic anemia. The red cells get coated with antibodies, and of course that those antibodies, immunoglobulins that got FC, will bind to the FC receptor on phagocytic cells, and they are going to be phagocytosed and eliminated and killed. So NK cells also. So any cellular or humoral component that you have heard so far about in the immune system, they're all parts of participants in autoimmune diseases as well. Okay, so that was simple. Some autoimmune diseases can be classified sort of, vaguely, really. And I don't particularly like that, but that you will see that classification. There are certain autoimmune diseases that are organ-specific, very much organ-specific. In other words, the immune components that are being activated only damage that particular organ. And an example I could give you is autoimmune Hashimoto's thyroiditis is one of the examples. Okay? Addison's disease. And we'll talk about what organs are involved in those diseases. So they are organ-specific. And then there's a spectrum where there is both organ-specific and non-specific interactions. Okay? And then there is some that is just non-organ specific. And the best example of that extreme is systemic lupus erythematosus. In SLE, where is the damage being done? Damage is being done in the skin, erythema, but it's not the skin antigens that are responsible for that. The antibodies or immune components are not against the skin. It's DNA, anti-DNA antibodies or anti-nucleoprotein antibodies that are forming immune complexes, depositing themselves into the vasculature, microvasculature, and causing damage there. So the nephritis that results from the that is a part of SLE is not due to antibodies against kidney tissue antigens, but it is against DNA and other nuclear components, but the kidney is being damaged, so that's non-organ specific. So I've already explained that. Okay, what are they? Here is some examples of that. Okay, insulin-dependent diabetes is an example of, obviously, on the left-hand side, all those are examples of non-organ specific, organ-specific autoimmune diseases. And here, muscle dermatomyositis, kidney SLE, skin and scleroderma, joints, rheumatoid arthritis. In rheumatoid arthritis, the antibody is not against the synovial membrane or synovial components. Antibody is against IgG, immunoglobulin. Forms immune complexes, causes inflammation, and causes damage to the joints. So those are the examples of non-organ specific. Okay. I'm going to give you a whole list, and the last page of your handout has got a big list of different autoimmune diseases. What do you want to do? Memorize it all. Well, you need the information, but I'm going to give you a trick. When I say Hashimoto's thyroiditis, there is no secret what organ is involved. Okay? So you've got to concentrate only on a few where it does not mention the organ. Okay? Addison's disease, Graves' disease. Okay? So where there's no link between the organ and that. So in that list, you will find only a few of them that here got a list. Hashimoto's, the thyroiditis, antibodies to thyroglobulin and thyroid peroxisomes. If the antibody is against the tissue, okay, what sort of immunological test you are going to use? Dr. Mayer told you about it. Immunofluorescence, tissue-bound, okay? Immunofluorescence. If it is soluble antigen, what are you going to use? Either ELISA, radioimmunoassay, or passive hemagglutination, passive agglutination. Immunofluorescent, ELISA, are the tests, and I want you to know that. Okay? Graves' disease is thyroid, is the organ damaged, but the antibodies against TSH receptors, okay? And TSH receptors, antibodies act as if they are stimulating, okay? Thyroid stimulating hormone, they act as. And there is a bioassay as well as ELISA for it. Pernicious anemia. Anemia, as soon as you hear the word anemia, red cells are being damaged, right? Wrong. Pernicious anemia has nothing to do with the red cell antibodies. It's antibodies against intrinsic factor, okay? All right? And there are some antibodies against gastroparietal cells as well, but by and large the anemia is because of the antibodies against intrinsic factor. Intrinsic factor is important for transporting iron, vitamin B. Okay? Vitamin B12 deficiency ultimately leads to anemia. So when you hear pernicious anemia, don't just straight away jump to anti-red cell antibodies. Okay. In diseases involving tissues, damage is also caused by cytotoxic T cells. So when you say thyroiditis, it's multifactorial damage. There are antibodies against the thyroid peroxisomes and thyroglobulins, but there's also cell-mediated cellular infiltration. When you see, they cover it in pathology, they'll show you slides of pathological slides, and there is a inflammation and accumulation of mononuclear cells in that area, and a lot of them are autoreactive T cells as well there. Okay, Addison's disease, I'll just give a few more. Adrenals are involved in that case, antibodies to adrenal tissue, and immunofluorescence obviously is the test. Insulin-dependent diabetes, pancreas, pancreatic beta cell antibodies against indirect immunofluorescence. Good posture syndrome, kidneys, and lung, basement membranes of the two organs, and the renal and lung basement membrane damage, and antibodies there, and indirect immunofluorescence. I'll give you some. Okay. Here is the examples of Hashimoto's thyroiditis. Here is the peroxide histology, histochemical test here, and you can see antibodies accumulated there. But you also see the infiltration of mononuclear cells, inflammatory cells. Here is the indirect immunofluorescence, and this is should be green, but it got bleached out, I guess. Okay, in Graves' disease, well, that's just a patient example. Here's the antibodies that bind to the TSH receptor and stimulate these cells to produce large amounts of thyroid hormones, and that has physiological features there. Okay, intrinsic factor, just to give you a cartoon illustration, intrinsic factor normally binds to that, and B12 is absorbed, but in the patients it's blocked by the antibody, and therefore B12 cannot bind. Oral B12 is not going to help. It's got to be injected with B12. Okay, myasthenia gravis, antibodies against acetylcholine receptor. Okay, and antibodies bind to that, cause them to be internalized so that the receptors are not at the surface. Okay, or the receptors are blocked. Either way, there's a lack of neuromuscular transmission, reflected by lazy eye syndrome sort of thing, movement, muscle weakness. There are some anti-muscle antibodies in these patients as well. Okay, and there's also inflammatory cells accumulating in the muscle, histopathologically. Pemphigus, okay, immunofluorescence, detection of anti-desmosomal antibodies. Desmosomal, those are proteins between cells, and causes blistering. And similar symptoms, but it's called pemphigoid, pemphigus-like, and in this case the antibodies are against basement membrane. I'm giving you the whole list where there is no connection between the name and what the antibodies are. Those are the ones that you've got to memorize. Okay, Sjogren's syndrome, lacrimal gland. Okay, secretory glands. So these are characterized by dry mouth, dry eyes, scratching, secondary infections, and so forth. And one can detect antibodies against duct mitochondrial antibodies. They damage those cells, and they are not capable of secreting. So that's why dry eye, dry mouth. Okay, but there's also cellular infiltration. So you've got to remember that, both cell-mediated and in case of rheumatoid arthritis, of course, the joints are involved, and you will see a lot of those in rheumatology lectures and in pathology lectures, and there the antibodies are against immunoglobulin, referred to as a rheumatoid factor. Okay? But those are anti-IgG antibodies. If they are anti-IgG antibodies, how can you detect? You can do ELISA, of course, but it has got to be altered IgGs. That IgG is somewhat altered. So what one uses is aggregated immunoglobulins that are on latex particles, and the antibodies bind and agglutinate the latex particles. Or you can use any anti-red cell antibodies and add them. It works like an indirect Coombs test almost. Okay? Indirect Coombs test, and it is going to agglutinate those. In the old days, that's what the test used before they came up with the latex agglutination test. Instead of latex agglutination, they used anti-red cell antibody, and that was referred to. You may still see the name somewhere, Rosewaller. It's not in your handout. If you want to write that, I'm not going to ask you the question, but if you see what a Rosewaller test is, that's what the Rosewaller test used to be. Red cells, sheep red cells coated with IgG, okay, and their agglutination by rheumatoid factor. Okay? All right. In lupus erythematosus, that's probably the last one, you get immunofluorescent detection of anti-nuclear antibodies. There is a latex test as well for that, where the latex particles are coated with DNA or nuclear material. And you can do that agglutination, but most commonly it's done by immunofluorescent. You can see the bright nuclei. Okay? Patient's serum is taken, put onto a tissue that will combine with nuclei, and then you use fluorescent anti-immunoglobulin to detect that antibody. Okay? And that's an example. Here is the example that these patients, they also deposit their antibodies and antigen complexes in different organs. And here is a biopsy of renal tissue stained with that. And if you look at it, there is one here and one here. Okay, you can see the clear difference. This is the lupus. Remember that if it's immune complexes, when it gets deposited, it's not going to get deposited in a nice manner, just layered, okay? It's going to be randomly distributed as lumps. And that pattern of staining, you should remember, I'll come back to it when I'm talking about hypersensitivity. That's a typical characteristic appearance of immunofluorescent staining of immune complexes in case of lupus nephritis. Whereas on the right is a different one. You can see very smooth linear staining. And that is because it's antibodies against basement membrane. Now the antigen is very, very smoothly, very uniformly distributed, and therefore when antibody combines with it, it's going to be very linear and smooth. And you detect those antibodies by anti-immunoglobulin, of course, that is fluorescent. Okay? So that's lupus. All right. Few things about autoimmune diseases. Autoimmune diseases occur in clusters. Okay? There's a question before I go. The deposition of immune complexes and therefore the leaky blood vessels and erythema. And when we talk about hypersensitivity, we'll come to the mechanisms later on. Okay? That's why it's called lupus is a sort of word wolf-like. Okay? Erythematosus, redness, erythema. Okay? And it's systemic because those immune complexes can be deposited anywhere in the body. That's why the name SLE or systemic lupus erythematosus. Okay. Autoimmune conditions, diseases occur in clusters. They are often together, okay? In other words, antibodies against one's organ or tissue in an individual, and the same individual may have antibodies against other autoantigens. And here is a sort of distribution overlap cartoon diagram. If they have got gastric parietal antibodies or intrinsic factor, anti-intrinsic factor antibodies, they often may have antithyroid antibodies as well. And individuals that have got anti-nuclear antibody, like in SLE, they may also have anti-intrinsic factor antibodies, and there are some populations, and some of them may have anti-thyroid antibodies as well, coexisting. So there's a predisposition to autoimmunity, and the organ or antigen is selected either uniquely or combined. And there are some people who may have antibodies against all three. Okay? So it occurs in cluster. There's a familial predisposition to autoimmunity. And here's an example. Mother and father, antibodies against thyroid in mother. Father condition not really certain whether he had any autoantibodies or not. Peculiarly, females for some reason are more prone to autoimmune diseases than the males are. Okay? So anti-thyroid antibodies here, the offspring, pernicious anemia, as well as anti-thyroid. Here's another offspring, pernicious anemia, thyroid. Atrophic gastritis means anti-gastric parietal cell antibodies here in this case, pernicious anemia, as well as the thyroiditis here. Okay? Only pernicious anemia, only thyroid. So the offsprings, the progeny of individuals with autoimmune disease are more prone to having autoimmune conditions. So there is some genetic basis for it. What it is not known. There is some association with certain HLA types. And they are the risk factor. If they are DR3, they are much more at risk for Addison's disease, or they are B8. B8 and DR3 are close together. Remember, they will probably travel together as a haplotype. There's less chance of a crossover there than other places. Okay, so and B8, DR3, DR4, and DR3 for insulin-dependent type 1 juvenile diabetes. They're more likely to have a higher risk. Rheumatoid arthritis among people who are DR4 and B8. So B8 seems to be baddie, and after that DR4 or DR3. Why? You know that there are certain MHC antigens that are going to combine certain immunodominant peptides and respond to that and then help B cells to produce antibodies. So the genetic predisposition based on HLA is not a surprise. Okay, etiology, totally unknown. That's one word. There are lots of hypotheses and lots of experimental evidence for it. Sequestered antigens. Obviously, negative selection is not going to take place if the antigen is sequestered. Okay? Thyroid hormones, not represented in the thymus. T cells are going to come out, and they are dampened, they are suppressed by other immunoregulatory, and that's where probably the genetic predisposition is, that these individuals cannot control that reactivity of those cells that are not becoming tolerant in the periphery. So, sequestered antigens. It has been observed that after surgery, the antibody titers against nuclear factors, anti-nuclear antibodies, titers go up. It comes down again, but in autoimmune individuals, if they are prone to SLE, they're not going to be coming down. After orchiectomy, testicular surgery, there's anti-sperm antibodies transiently appear because sperm antigens are very much sequestered, not exposed, but then during surgery the immune system gets exposed. Escape of autoreactive T cell clone, I've already mentioned that. Not every clone is eliminated in the thymus by negative selection or in the bone marrow for B cells. They do escape, and in some individuals, for some reason, they are not rendered tolerant, so their activity suppressed in the periphery. to give you a little bit of additional sort of information in that regard, it's been postulated they are very low in highly positive, strongly positive CD25 T cells, which are downregulatory cells. Is it the only cause, or is it established? No, it's all still in the experimentation. Okay, cross-reactive antigens. I told you about that after certain infections, there are antibodies produced that cross-react with the cell. Post-streptococcal myocarditis. Anti-heart valve antibodies are produced after streptococcal infections. Modification of self-antigens. Viruses, when they infect cells, they can modify the antigens. Or haptens, chemicals, can modify antigens, and the cells become reactive to cells. Most individuals are fortunate enough to control that reactivity, and when that chemical or that agent has been eliminated, they come back to the normal state. Some of us genetically prone to such condition that we continue to produce antibodies, those antibodies. Exogenous antigen, the same thing I already talked to you about. Cytokine dysregulation and inappropriate MHC expression. MHC that is such that can recognize certain epitopes on foreign proteins, foreign antigens, that can stimulate T cells in such a way that they help the B cells to produce antibodies against self. There are some cytokines that downregulate the immune response. IL-10, Dr. McCallum, I'm sure, mentioned that. I know he did mention that. And the dysregulation of those cytokines can lead to autoreactivity. Suboptimal immunoregulatory functions. Is any one of them is definitely proven to be associated with that? No, they are multifactorial. There are observations for all of those hypotheses to support. Okay? All of those mechanisms are supported by observations in the lab, clinical observations in humans. Okay? There are experimental models as well that have produced results to suggest that one can immunize animals to antigens that are normally restricted to a certain organ, restricted to certain tissues, sequestered antigens, and produce autoimmunity in animals. And I'll give you some animal models because you will come across those in either boards or otherwise. Okay. Treatment, systemic corrections of metabolic consequences. Thyroiditis, thyroid hormone dysregulation, they are corrected by iodine, okay, radioactive iodine or other means if it is hyperactive. Okay. Conventional immunosuppressive agents. In your transplant lecture, remember that I showed you tables, and you've got tables in your handout that same immunosuppressive agents like methotrexate or azathioprine or prednisone are used in autoimmune disease as well. Is there a cure for autoimmunity? No, there is none. People are developing some immunological approaches to control it, but at the moment there is no cure for autoimmune diseases. Experimental treatments, induction of tolerance by oral administration of antigen being tried. Is it a standard treatment? No. Anti-idiotype antibodies, okay, are being used to control autoimmune diseases. And there are lots of bioengineering companies that are experimenting with these. And there are some actually in clinical trials. Experimental models, you've got to be familiar with that because you're going to see that. I've seen it being asked sometimes in the boards. Not every one of you will get the same module, but some of you may be unlucky enough to get those. So if you remember it, there are experimental models of autoallergic encephalitis, whereas myelin protein is injected in Freund's adjuvant. Adjuvant, remember the adjuvant word adjuvant, that is any substance that can increase the immunogenicity of a particular molecule. And Freund's adjuvant is a particular formulation, which is oil emulsion. It's like mayonnaise, actually. It looks like mayonnaise. It forms an antigenic depot. Anyway, if you immunize against that in certain strains of mice and rats, you can produce encephalitis. Thyroiditis, you can take thyroid tissue, grind it up into adjuvant, immunize animals, and they come down with thyroiditis. Adjuvant-induced arthritis, you can inject adjuvants into the foot pad, and they will come down with arthritis, certain strain of mice and rats. Uveitis, our ex-chairman was his field of research. The certain antigens from the eye can be used in adjuvant and produce uveitis. There are others, and there are some natural models. Here is an example of encephalitis. Okay. There is in natural strains of mice, they are naturally prone to autoimmune diseases. That is actually the oldest observational tool that has been used to prove that it is genetic. These mice, 100% of these mice come down at 4 to 6 months of age starting that age, with autoimmune hemolytic anemia, and later on they may develop some nephritis, but not all of them, not a very high rate of nephritis, hemolytic anemia. And take these mice and cross them with another strain of mice, which is New Zealand white mice, and now they become autoimmune. The model for lupus model. So that again tells you an experimental basis, gives you an experimental basis for the hypothesis that there is genetic predisposition to disease, and then the different genetic background may determine what organ and what antigen the autoantibodies will be against. Non-obese diabetic mice, they are mice that develop diabetes. And that's a model for autoimmune diabetes. Okay, that's all I had to say about those diseases.